first speaker, who's Dr. Sherry Ann Nathan. She's a professor and chairman of LSU HSG Shreveport, Louisiana, and she's going to be talking about novel testing for HPV.
Good afternoon, everybody, and I'd like to thank the organizers and the moderators for the opportunity to speak today about an exciting topic that's constantly changing. So I have nothing to disclose. I think we've all heard at the meeting how HPV is the best biomarker we have to date. It's a major prognostic and predictive marker now included in the NCCN guidelines. The detection, though, has therapeutic implications, and now, especially with the two trials, ECOG 3311 and RTOG 1016, I think it's important that we have some consensus on the optimal way to identify HPV. So I'm hoping today to review the various techniques that are used clinically, and maybe even look at methods to detect the possibility of infection in serum and saliva, and analyze some of the papers on the DNA RNA microarray platforms between the HPV positive and negative tumors. So clinically, we know when we see a young male non-smoker with a base of tongue or tonsil cancer, basaloid poorly differentiated, as you see here in this picture by Investra's article, you know it's most likely going to be HPV positive tumor. In fact, Lewis published his findings in 2012, where he looked at his personal collection of 293 patients of tumors and found that 98% of tumors were P16 positive by both immunohistochemistry and high-risk HPV RNA in situ hybridization for the non-keratinizing squamous cell. And for the keratinizing squamous cell, only 18% were positive for P16. However, we still need an even more sensitive and specific marker, something that's cost-effective, can be used in fixed tissue. And I think it's so important to standardize the methods so that these tumors are not misclassified, because, again, in clinical trials, we can influence outcomes if we've wrongly classified these tumors. So what are the various factors that determine these detection methods? You've got to look at the biologic sample. Is it fresh tissue, fixed? Are you looking at fine needle aspirates, saliva, serum? Identifying DNA, RNA, and viral oncoproteins is important, and in the fixation methods, there's degradation of the DNA, RNA, and proteins, sometimes making it difficult to identify them. And then the last question, do you look at just HPV 16, or should you look at a broader group of high-risk HPV? As seen here, we all know there's about more than 100 types of HPV, but the high-risk ones here at the bottom panel shows that even the high-risk, there's about 13 to 14 different types of HPV. So in this article by Chaturvedi in the Journal of Clinical Oncology, if you look at the right side, I don't seem to have this pointer working. Okay, here we go. If you look at the top right-hand slide, it looks at prevalence estimates corrected for potential loss and assay sensitivity. And the yellow line is the actual loss, and this would be the corrected loss for each time period, showing that there is a difference in assay sensitivity over time. So HPV cannot be cultured in vitro, and so molecular biology techniques are used to identify the various HPV proteins. The transforming potential of HPV is based on these two oncoproteins, E6 and E7. E6 inactivates P53 and E7 phosphoretinoblastoma. And this is a really nice schematic representation by Westra, which shows HPV infection to viral integration, transcription, viral oncoprotein translation, tumor suppressor inactivation, E7 inactivating RB that causes upregulation of P16. And with each one of these steps, you can see the DNA in situ hybridization, messenger RNA in situ, and P16 immunohistochemistry. And thanks to Carol Fakhri for lending me these slides. So Abrio here looked at the classification system for detection methods of HPV. And you can see there's nucleic acid hybridization assays, signal amplification, and nucleic acid amplification assays that include PCR, real-time PCR, and so on and so forth. So starting with the southern and northern blot, used mostly in the lab, they were the initial methods, required large amounts of material, could not be performed on the fixed paraffin-embedded blocks, time-consuming, and could only detect one HPV type. However, PCR, that's used in the lab and also clinically in some cases, using consensus primers, MY1109, and general primers 5 and 6, is commonly used today. In this article by Gillison and Westra, you see the diagnosis of HPV with in situ hybridization and P16. So on the left, you have your HPV negative tumor, and on the right, the HPV positive. By in situ, you have this punctate nucleus dark brown staining, indicating positivity. And normally, punctate indicates integration of the virus, whereas if it's diffuse, it indicates episomal form. P16, on the other hand, was actually identified by Klasman and al. In terms of its association with HPV, and is this diffuse nuclear and cytoplasmic stain. So the question is, integration is also questionable. In fact, Koskinen and Mellin, in both their studies, showed that HPV was present in the integrated form in only 48% of tumors, and 35% of them were episomal. And Mellin, in fact, saw that most of them were in episomal form. So how then does it cause the oncogenic potential if it's present in the episomal and not integrated? I think Fernandez and all hypothesized and showed that accumulation of CpG methylation in the HPV genome could correlate with increasing its oncogenic potential, even though in the episomal form. So Westra, in a recent study published in Oral Oncology this year, compared these two common techniques of PCR-based and immunohistochemistry for detection of HPV, and looked at the advantages and disadvantages of these techniques. So PCR is more efficient on frozen tissue. It's very sensitive, but not as specific because it's susceptible to viral contamination or just a passenger virus effect. And you cannot identify it in context of the tissue. And it's restricted to the molecular labs. But DNA in situ hybridization can be performed on paraffin-embedded blocks. It's very sensitive, very specific, can be visualized in its distribution in the tissue, and it's available for all surgical path labs, and so is a very good test. Schlecht et al. Published in Modern Pathology in 2011 comparison of 3 various methods that are used. P16 immunohistochemistry, and he compared it to in situ hybridization by Ventana and in situ hybridization by DECO. And if you focus here on the lower panel, where we're looking at oropharynx only, it's interesting if you look at specificity, P16 was 100%, but in situ hybridization by Ventana was only 30%, by DECO 100%. When you looked at the sensitivity, P16 90%, Ventana 67%, and DECO only 38%. So I think it was clear from this study that the sensitivity and specificity with these 2 techniques was questionable, and in fact I think Ventana now has taken it off the market, and it's not even available clinically because it was not FDA approved. So Bishop and all looked at tissue microarrays on 282 head and neck cancer patients and looked at P16, DNA, and RNA in situ. P16 was strongly associated with RNA-ish, and so was DNA. But there were 25 cases that were P16 positive and DNA negative. But the RNA in situ detected in these cases E6 and E7 transcripts in 84% of the cases. So clearly there was a stronger association between that and P16. And here's a picture from that article. You look at the H&E here. This is Ventana in situ hybridization of DNA. DACO showing a very faint signal, but using messenger RNA, you can see a strong signal in the same tumor that was negative by these methods. And this in itself, mRNA is a natural amplification method of the signal. So Lewis suggested that P16 could be used as a standalone test for stratification if there was greater than 75% nuclear and cytoplasmic expression. If between 50 and 75, then he recommended doing the HPV DNA by in situ hybridization. However, he went on to say that I think with the RNA-based tests becoming more widely applicable, validated, and cheaper, they may replace P16. Westra, in his publication this year, said P16 could be used as a standalone test when there's strong staining in the nucleus and cytoplasm in greater than 70%, but this was applicable only to oropharynx sites, and you should supplement it with typical morphology of basaloid non-keratinizing. So this is a study done in our lab which was really looking at why do these tumors only occur in the base of tongue and tonsil and not in the rest of the oral cavity that's exposed to HPV. And since it occurs in only lymphoid tissue, we hypothesized that it was probably a co-infection between HPV and EBV that caused these tumors to occur in the base of tongue. And this is in press currently in the Journal of Oral Pathology and Medicine. So we captured the epithelial cells with laser capture microdissection and first looked at HPV expression with both in situ and P16 immunohistochemistry in 120 normal and malignant oropharynx cases. And in our study too, we found a significant correlation between HPV status using both these techniques. And you can see here in terms of the co-infection rate, squamous cell cancer of the tonsil, 50% were HPV positive. 25% of the cases had a co-infection of HPV and EBV. Interestingly, in the base of tongue, 20% of the cases were HPV positive alone, but 70% of the cases were positive for HPV and EBV. So Jordan and all looked at validation of the methods, and this is a really nice study because they looked at it in all the US cooperative groups combined. And there were a large number of cases. And he looked at inter-rater agreement between P16 immunohistochemistry and HPV 16 in situ hybridization, comparing it to RNA. And there was a strong inter-rater agreement with kappa of 0.86 in this study. When they looked at sensitivity and specificity, and I apologize, this is very small, the font, but it was extremely sensitive, greater than 90% with P16 and less specific, and the opposite for in situ hybridization, it was less sensitive but more specific in the cooperative group trial. So Weinberger has actually classified these tumors into 3 classes. Class 1 is our typical tobacco alcohol tumor. P16 is inactivated, P53 mutation, HPV negative. This same tumor, when you have a superimposed high-risk HPV infection, becomes class 2, which is still P16 inactivation, P53 mutation, but now HPV positive. And then you have your HPV positive tumor where P16 is not inactivated, P53 wild type, and that's the HPV positive tumor. And in Weinberger's classification, here's really the tonsil carcinomas showing a class 1 HPV negative, P16 negative, class 3 positive for HPV positive for P16. Here's one that's HPV positive, but P16 negative. This is the superimposed viral infection. And class 4, where it's HPV negative and P16 positive, and that can occur because P16 could be activated by other molecular pathways. So Salazar looked at the overall and disease-specific survival by HPV 16 DNA and RNA detection methods. And he found that whether you used just the HPV 16 DNA or RNA, or used the combined definition, they were all significantly better for oropharynx tumors if they were HPV positive, no matter what method of detection was used, whether it was single or a combined method. So it did not change either the overall or disease-specific survival. Moving on to fine needle aspiration biopsies and identifying HPV. So in Begum's study in clinical cancer research, they looked at about 68 neck node specimens and found that HPV was detected in 17% of the aspirates. When stratified by site, there was a significant difference in HPV in those that were oropharyngeal tumors metastasized to the neck, and 0% in those tumors from other sites. Similarly, using immunohistochemistry, there was a significant difference in identification of HPV when the met was from the oropharynx. This was Westra's study, where he looked at a number of lymph nodes, almost 70 lymph nodes, and stained it with P16, and some of his tumors included unknown primaries, and he too found the same difference between the HPV positive and negative if they were from the oropharynx compared to other sites. Our lab performed a study that was published in 2011 in Otolaryngology Head and Neck, and we looked at only unknown primaries, neck mets from unknown primaries that had been worked up completely with panendos, tonsillectomy, PET scans, etc. This was different from Westra's study, where they looked at lymph nodes from various sites and not just unknown primaries. So we identified HPV using in situ hybridization, and we found that 23% of the lymph nodes were positive. And this could potentially indicate that the primary in those are from the tonsil or base of tongue, and hopefully in the future can target therapy based on the unknown primary. So going back to classification of HPV tests, let's talk a little bit about the signal amplification assays that are actually FDA approved for cervical cancer. So the two common ones approved, the hybrid capture 2 assay, and in that assay you denature, it's a liquid phase assay, you denature the specimen to release the target DNA. This is then hybridized with the HPV RNA probe as you see here. RNA and DNA hybrids are then captured onto this microtiter plate coated with monoclonal antibodies, the second monoclonal antibody conjugated to ALK-phos, and then you identify the signal. And I think Sarah Pai has a really nice paper looking at the number of viral copies needed for identification of this. So Smith this year published a study looking at whether you could use this technique for FNA specimens using the hybrid capture assay. And he found that the HPV status was correctly identified using this technology in 84% of cases. However, when they only looked at nodes that were not necrotic or cystic and on histology were able to identify cancer cells, that accuracy using this technique increased to 100%. The second test, the Cervista Invader test, also FDA approved for cervical cancer, is very similar. It's another liquid phase assay. The only difference is it has an internal control compared in terms of the quantity of DNA compared to the hybrid capture assay. So again, this year, in cytopathology, Go and al. Performed a study on FNA specimens looking at the Cervista technique and found on 64 FNA specimens, Cervista and both HPV high-risk assays were positive in 75% of the patients, and there was an overall agreement of 94%. So what about some of the additional molecular markers? Transcriptionally active HPV is known to be absent of TP53 mutations and limited number of genetic abnormalities, whereas their counterparts without transcriptionally active HPV, TP53 mutations in CIFs are present in 75% of cases. Brackhouse and al. Published a study in JNCI in 2004 where they looked at loss of heterozygosity using microsatellite markers and found significantly lower levels of allelic loss at chromosome locations 3p, 9p, and 17p in the HPV positive compared to negative, as well as another study by Reagan looking at 11q13 amplification was not as common in HPV positive tumors. So this year, Redbergen published in the International Journal of Cancer a really nice study again looking at genetic profile of P16 positive compared to negative cases. So here you have your HPV positive and HPV negative. The light gray shows no loss of heterozygosity and the dark loss of heterozygosity. And you can see that there's significantly more no loss of heterozygosity in the HPV positive compared to the negative. Now there were 10 cases that were discordant where P16 was positive, but it was HPV DNA negative by in situ hybridization. And you can see in those cases there was a lot more loss of heterozygosity, indicating these were more likely to be HPV negative tumors. Next-gen sequencing being commonly used now again to identify various molecular profiles of these tumors. And this is a very nice study again by Leshner in Genome Medicine, where on the right side here you have your HPV negative tumors, and here you have your HPV positive tumors. The dark blue shows mutations. The black is mutations and the dark blue deletions. And you can see in your negative tumors, there's a lot more mutations and homozygous deletions compared to your HPV negative positive tumors. So finally, let's talk a little bit about seropositivity and identification in serum and saliva. D'Souza and all published in New England Journal that whether you had an oral HPV infection, if it was seropositive, or you were seropositive for E6 or E7, you can see the odds of having an oropharyngeal cancer was significantly higher. Some other population studies done in Sweden and Norway both showed detection of oral infection significantly increased the risk of oropharyngeal cancer. And so did Gillison in her study. So looking at antibodies to L1A antibodies in another study here by Furness and al., he showed that with increasing titers, there was a significantly higher risk of oropharyngeal cancer, with medium titers resulting in a 4-fold higher risk and higher titers resulting in a 19-fold risk of oropharyngeal cancer. However, in this study by Ribeiro that was published in 2011, they got different results and showed there was no risk of increased incidence of oropharyngeal cancer with increased L1, E6, E7 in their study. And this was true for both patients from Latin America as well as Central Europe. In terms of saliva, using the Orogene kit, they were able to identify HPV in these tumors. And even at the lower cutoff point at 0 or 0.001, you can see for oropharynx cancers, there was a higher risk of having positive saliva in HPV positive tumors compared to negative, and that was significant. Listed here are some newer methods of detecting HPV that I'm not going to go through, but these are up, and there's a number of studies being done with these techniques. So finally, in summary, I'm not going to go through these advantages and disadvantages, but I think this is a nice table in Robinson's article on oral oncology, which talks about the positives and negatives of each of these various techniques we've talked about currently. So there was a recent survey, informal survey of testing practices of North American pathologists, and there were 48 respondents, 90% academic. And the questions asked were, do you routinely perform, in every case, surrogate marker testing? 88% yes, 12% no. What are the testing utilized? P16 alone, 50%, 42% said HPV DNA in situ alone, and only 8% were performing both P16 and HPV DNA. So I think the major questions we've got to ask ourselves is HPV testing needed for patient care? And I think we all say yes. What is HPV-specific tests can be used in routine practice that sensitively identifies our transcribed active high-risk HPV? And is there patient benefit that justifies millions of dollars of expense in additional testing? These are the questions we've got to ask ourselves as we come to some kind of consensus on the methods to be used. So in conclusion, I think Robinson shows here in this nice flow chart, P16, if it's positive, if it's negative, no HPV. If it's positive, HPV 16 by ISH. If that's positive, then you've got an active HPV. If it's negative, still go ahead and do consensus PCR. If it's negative, no HPV, but if positive, that's an active HPV infection. Thank you.